Hi, everyone. My name is Nandini Raj. I am a patient partner on the Patient Advisory Council with Long COVID Web. It is my honor today to present Ethan's story. Ethan is a 13-year-old boy who lives in Ontario. He was unable to be present with us because he's very sick, but we are very honored to have his mother, Rebecca, and his sister, Eva, to be here at the conference. I will start by telling you a little bit about Ethan, and then we're going to show you a little clip, a little glimpse of his life. And then we're going to introduce Dr. Rao, Suchitra Rao. We're very honored to have her all the way from Colorado to speak about long COVID in children. Can everybody hear me okay? Yeah, okay. Ethan was a fun-loving 11-year-old till he started living with long COVID in May 2022. Ethan used to play hockey and train in mixed martial arts, loved school, and enjoyed spending time with his friends. He loved the outdoors and getting out on the trails for a hike. In the last 28 months, his life took a drastic detour. Ethan's first COVID infection was at the end of April 2022. And within 2 weeks of his acute infection, he developed life-altering symptoms that were unexplainable, one of which was the constant abdominal pain and nausea that went on to significantly affect his quality of life, ability to sleep, and attend school. Unfortunately, with his second COVID infection in February of 2024, his symptoms have gotten progressively worse. He is now unable to attend school or indulge in any physical activities that he used to enjoy so much. Ethan has had to learn to advocate for himself at a very young age, as he has experienced clinicians brushing off his symptoms as anxiety and not being believed early on. He often talks about those interactions that he experienced with sadness. It caused him much more distress on top of everything else he had to deal with in his body. Ethan just wants things to go back to how he was before he got sick. Now, at 13 years old, he wonders if he will ever feel better again. I will introduce Dr. Suchitra Rao. Dr. Rao is an associate professor of pediatrics and infectious disease physician and hospitalist at the University of Colorado School of Medicine and Children's Hospital, Colorado. Her research activities have focused on the epidemiology and clinical outcomes of the respiratory viral pathogens in children. Did I get that right? She has spent the last 18 years studying respiratory viruses with a more recent focus on influenza and COVID-19. She's involved in several multi-center studies to evaluate the clinical outcomes and host response to infection of children with influenza and COVID-19, as well as studies on vaccine effectiveness and clinical outcomes of pediatric patients. She is one of the principal investigators for the NIH Recovers Pediatric EHR Cohort Initiative and has published extensively on the presentations of long COVID in children. In her recent editorial titled Uncovering Long COVID in Children, which was published August 21st, 2024, in the Journal of the American Medical Association, she says there is a clear emphasis that there needs to be a much greater focus on the effects of long COVID in kids. Much of the accrued data and research on long COVID to date have focused on adult populations. We are so grateful and so honored to have Dr. Rao all the way from Colorado to come here and present about long COVID in children. So we can start by showing Ethan's glimpse of life with long COVID.
She's 5 months old. And your mommy, that's right, your mommy tells me that I don't take enough video. So here I am taking video while they're all out having fun and partying. So, Ethan, hi. Hi, he's a smiley boy, right, Ethan?
Ethan was born May 2011. He was born healthy. Within a few days, we realized he was one of those babies who would always be laughing. Unbelievable at the time, but we found him at 3 days old laughing in his bassinet. As Ethan grew up, we realized he had such a joy for life and was a very resilient child. He loved to hang out with his sister, made friends everywhere he went, loved school, and excelled at mixed martial arts and had a true love for playing hockey. One of my friends said he was like a little Buddha, always enlightened and happy.
Say, can I have veggies?
Can I have veggies?
No, you can't because you don't feel well.
I don't like veggies. Yes! Commercial. Now, if you want to be a rhino, use the same costume. Put it on like that. Hold on to the straps and go.
Everything changed May of 2022. He came home one day from school, wasn't feeling well. He wasn't even that sick. He just complained his nose was runny and he had a bit of a sore throat. We swabbed him. He had COVID-19. Within 2 weeks, although all of his symptoms were gone from his COVID-19 infection, he started complaining of abdominal pain. First, it was infrequently, a few times a day. Then it became more and more often. Eventually, he started waking us up in the middle of the night because the pain was so bad he couldn't sleep. Then the nausea started. He was walking around that summer with a container because he felt so nauseated he thought he was going to throw up. When the school year came around, we realized he wasn't able to go to school the way he used to. And that was the beginning of his journey with long COVID. Months into his illness, many tests had been done. They couldn't find anything wrong with him, but by that point, the pain and the nausea were so bad. He also developed an intolerance to heat. He was struggling, in pain and suffering. He had scopes done, and finally we ended up in front of the doctor, the gastroenterologist. She sat in her office in front of her computer and said, "Ethan, I can't find anything wrong with you. You just must be an anxious child." Ethan looked at her as cool as a cucumber, as relaxed as possible, considering he was suffering and in pain. Looked her straight in the eye. He was only 11 at the time. And he says, "I am not an anxious child. I am in pain." And that was the beginning of our journey to get the proper support for long COVID. I miss the laughter in the house. I miss the joy. I miss Ethan's voice as he plays with his sister. I miss seeing my children play together and interacting the way normal siblings should. Most of all, I miss seeing Ethan being able to do the things that a normal child at age 13 should do. It's heartbreaking, actually, because he doesn't have the support, and he struggles and suffers with pain and nausea every day.
I know, but we need to make the effort, Ethan. You lay down. How are we gonna do this? I don't know. We'll try for a bit. We'll go in, okay? I know. We're gonna try for a bit, though. Come for 5 minutes. We'll walk in. He's hurting so much.
I hope and pray one day that Ethan will get the right symptom management, the right treatment, and the cure so he can get on with his life. Just like Ethan, I know there are so many children in Canada suffering in silence with long COVID. I've been very fortunate that throughout the course of this medical journey that I've taken with Ethan, I recently had the chance to meet another mother who has a teen daughter that has been living with long COVID for 3 years. I realize now that Ethan is not alone. If there's one takeaway we can have from all of this as well, it's a reminder that these children are not having symptoms because it's in their heads. They really feel horrible. They really are suffering. There's a lot of children out there that are struggling. The medical and social stigma of long COVID is real for Canadian children.
How is life different since Ethan has been living with long COVID?
Our lives have been significantly impacted since Ethan's been living with long COVID. Family time or just time in general is hard to come by with my brother. Ethan's always living in constant pain, and that's just become the norm. It's really hard to see my little brother in a constant state of pain and distress.
As Ethan's sister, what message do you want to give out to the siblings of other families that have a child with long COVID?
As Ethan's sister, I just want to say to other siblings, everything will be okay. Our siblings just need the right help and support.
What would you like to say to any doctors that might be listening?
To any doctors that might be listening, I'd like to say, long COVID is real, and it's affecting my little brother. He spends every day, every moment in pain, and that's not fair to him. We need more medical research and government funding to find out how to solve this problem, and that can help start with you. We need your help.
Hi, everyone. Wow, that is an unbelievably difficult thing to follow, to come up after hearing those two stories. I just wanted to take a moment to acknowledge and thank Ethan and his family for sharing that unbelievably powerful story. Please keep doing that. It really gives us as sort of clinicians and as researchers sort of the motivation into why we are doing what we are doing. And also to John, a huge thank you for just really being able to present in such an eloquent way your story through words and images, really having a lasting impact on me and I'm sure a lot of people here today. So good morning to everybody. It is such an honor to be a part of this long COVID symposium. Thank you for the invitation. I've really enjoyed the sessions. I really enjoyed the way that this has been put together. And I've also had a lovely opportunity to meet many of you here as well. So thank you again for the warm welcome and invitation. So as you heard, my background is in infectious diseases. So I'm a pediatric infectious diseases doc. I work at Children's Hospital Colorado, and I do a lot of respiratory pathogen research. And it was really encountering patients and children and youth like Ethan that really motivated me to get involved in understanding long COVID in children. And so I want to tell you a little bit more about some of the work that I'm doing in this area and some of the work that we're doing in the US. So I don't have any significant disclosures. So just to launch into what I want to cover for this morning. So, I think one of the things that still people are having sort of a hard time recognizing is that long COVID does exist in children as well as in adults. So I'm going to talk a little bit about how we are seeing those manifestations in kids. The second thing I want to cover is some of the questions that we're endeavoring to answer within our research team. And then lastly, just to think about what some of the next steps are going to be as we think about ongoing dedicated research efforts to long COVID in children. So we heard a number of stories this morning. I'm going to give you yet another story, and this is really the motivation behind why I got interested in long COVID research. So this was a teenager that I had the fortune of meeting a couple of years ago. This is not her actual picture. This is just a photo that I found that reminded me of the photo that her mom had showed me on her phone of what she looked like before she got sick with COVID. So I met her when she was 16. So she had developed COVID in November of 2020. And the way that she had it was very sort of standard in terms of her SARS-CoV-2 infection. So she had fever, she had cough, she had shortness of breath, she was having chest pain. And then over the next several weeks, she was having a lot of difficulty with recovering. She was having ongoing shortness of breath. She was having a lot of diarrhea. She was having ongoing fevers. And then she developed a rash that I'll tell you about. She had swelling of her hands and her feet, and then she was having a lot of oral lesions in her mouth as well. And then over the next several months, her rash became more progressive and more debilitating. So I've never seen anything like it. So it was looking like small bruises all over her body. It started off on her face, then it progressed to one side of her body and then to the other side of the body. And again, exquisitely tender, very painful. And then with all of this, she also developed new onset asthma. She was also having irregular heartbeats. So she was in the hospital for months. So we got involved as an infectious diseases team, and then she had additional consultations from just about every subspecialty group in the hospital, from rheumatology to pulmonary to immunology. She was seen by dermatology, acute pain, ophthalmology, just to name a few. She underwent numbers of skin biopsies and other procedures. She ended up getting treatment with IVIG, with steroids, and several courses of remdesivir. And in the end, she was diagnosed with a very rare autoimmune condition that was contributing to all of her skin manifestations and many sort of long COVID symptoms. And she requires ongoing multidisciplinary care for long COVID years after her initial diagnosis. So as you are a very well educated audience, I know I don't need to go into sort of the definitions of what long COVID is, but I just wanted to highlight that one of the things that I'm sure is very challenging as someone with a lived experience, as well as a clinician and a researcher, is just how there are still these different definitions of long COVID that can make it very confusing and challenging to do research. So some of the terms that we use are things like the post-acute sequelae of SARS-CoV-2. This is talking about some of these symptoms or health effects that is present for 4 or more weeks after the acute infection. Now, that is something that is used a lot by the National Institutes of Health in the United States. And then the Centers for Disease Control in the US uses post-COVID condition, which is new symptoms developing 3 months after the initial SARS-CoV-2 infection, with those symptoms lasting for at least 2 months with no other explanation. And then the World Health Organization also has its own definition, and a smaller group within the UK came up with sort of a dedicated pediatric post-COVID condition as well. And this is at least one physical symptom persisting for a minimum of 12 weeks after the initial infection that can't be explained by an alternative diagnosis, has an impact on everyday functioning, and may fluctuate or relapse over time. And more recently, the National Academies of Science, Engineering and Medicine have also come up with its own definition, and they're really trying to push for researchers to try to adopt this definition so that we can try and be more standardized in terms of the way that we do research. And this is something that applies to both kids as well as adults. And it's described as an infection-associated chronic condition that occurs after SARS-CoV-2 infection, is present for at least 3 months as a continuous, relapsing and remitting or progressive disease state that affects one or more organ systems. And then it goes on to sort of describe that it can manifest in a multitude of different ways, that it can be single or multiple diagnostic conditions, that it can range from mild symptoms to more severe ones, that it can be single or multiple symptoms, and that it can follow either asymptomatic or mild or more severe SARS-CoV-2. So I really do appreciate this definition. I think it's sort of all-encompassing. And again, this applies to pediatrics as well as adults. So this is the way that we've actually been thinking about studying long COVID in children. So this was from a research article that we put together and published in Pediatrics. It's a state-of-the-art review on what is known about long COVID in children. And so when we think about this, I think about it in terms of this sort of conceptual model where long COVID can be persistent symptoms from the acute infection. It can be completely new and very distinct from the original sort of SARS-CoV-2 infection. And MISC, or multi-system inflammatory syndrome in children, is one of the more severe post-acute sequelae that we've seen. And it can also represent the exacerbation of underlying conditions as well. And so this, when we sort of do research studies and think about long COVID in kids, we're sort of using this conceptual model. And so I talked about MISC. So this is something that we have seen a lot in the sort of the hospital-based setting, and is one of the more severe complications that we see in kids after having COVID. And it is when you have fever, as well as a lot of illness that brings you into the hospital. You need to be hospitalized, and a lot of evidence of systemic inflammation, which is usually obtained through blood work, as well as having a lot of multi-system involvement. And so this diagram just shows you some of the organ systems that are involved. So it can manifest with red eyes, it can manifest with oral mucus changes, with respiratory symptoms, abdominal pain and diarrhea is a very strong feature of this as well as skin rashes and inflammation of the heart and the arteries to the heart. And there is the need for this sort of epidemiologic or sort of history of having SARS-CoV-2 as well. And this, when it first was described and we were seeing it at the beginning stage of the pandemic, it was resulting in mortality in 1% to 2% of kids. Thankfully, the numbers have gone way down now sort of into 2024, but we still do see this presentation in kids as well. So, we had talked about how there had been more research and sort of more things known about long COVID in adults. And so there were a number of folks from the pediatric community, either the research community, the clinical community, or sort of the general community, really saying that, hey, this is going on in kids too. We're seeing this in our populations and in our children in our community, and we really urgently need more research. So this is an example of an editorial that was published in Nature back in 2022 that was really trying to say, hey, everyone, we need to be looking at this in kids as well. And so that is sort of, I think, one of the impetuses that we had seen for ongoing sort of support and research efforts into long COVID in children. And so in response to this need, the United States National Institutes of Health dedicated $470 million to the development of the Recover Initiative. So I wanted to tell you a little bit about what that initiative involves. So it stands for Researching COVID to Enhance Recovery, and it is funded by NHLBI, which is one of the branches of the NIH. And it is a consortium of multiple different sort of researchers and folks who have lived experience from across the US. Over 200 centers in the country are involved in these efforts. And it is exploring through lots of different sort of research approaches, exploring different questions in long COVID in both pediatrics as well as in adults. And so here are some of the different components. So there is one group that is focused on enrolling adults. There is another group that is focused on enrolling children, and I do some work with the pediatric prospective cohorts. And there is also another group that is looking at real-world data or electronic health record data to answer those questions, one focused on pediatrics and one on adults. And so I'm one of the principal investigators for the real-world data, and some of the research I'll talk a little bit about. And so they're trying to amass lots of different data sources to answer long COVID questions. And here are some of the main sort of branches of questions that we are trying to uncover through this initiative. So one is focused on sort of detection. So what is long COVID? What does it look like? How does it manifest in kids? How might that be different from what we're seeing in adults? The next is focused on prediction. So is there a way for us to know who is more likely to go on to develop long COVID when they get a SARS-CoV-2 infection? Another one is on treatment. So what are the effective treatments that are evidence-based that we can use to really alleviate the suffering of people with long COVID? And then finally, prevention. So what are some preventative strategies that we can have that are in place to try to minimize the risk of ever having long COVID in the first place? So I'll go through each of these different endeavors as we go. So first, in terms of sort of detection or description of long COVID in kids. So the main thing that I think is important to convey is that long COVID can really affect any organ system in the body. So that is true of adults and that is true of pediatrics as well. So in our state-of-the-art review that we published, we did a very extensive literature search to find all of the different manifestations that have been described in kids. And so you may not be able to read all of the small print, but the big takeaways are all the organ systems you can imagine can get involved. And there's a lot of overlap with what has been described in adults being seen in kids as well. But I think the relative proportions of those symptoms and conditions are sort of different depending on the age group of the individual. So in kids, a number of the manifestations that we see more frequently involve sort of the constitutional side of things, so entire body systems where we're talking about fatigue and malaise, general aches and pains, the brain fog, sort of difficulty with concentration and memory are very sort of pronounced symptoms. Similarly, we see a lot of neurologic symptoms like headaches, dizziness, sort of difficulty with cognition, memory, that sort of thing. And then we're also seeing a lot of respiratory presentations, so persistent cough, wheezing, new onset asthma, chest pain. And then, I also want to recognize that there are a number of other sort of phenotypes or sets of symptoms as well. So GI manifestations is a very important one in pediatrics too, as well as some of these musculoskeletal sort of really debilitating pain states as well. So what about the frequency of long COVID? So how often or how common is it in kids? So it turns out this is an extraordinarily difficult question to answer. And some of that comes back to what I talked about before, about how there are a lot of different definitions for long COVID. And so depending on the definition that you use, depending on the population that you're looking at, depending on the setting, you can get really vast differences. So some of these studies look at just kids in long COVID clinics, where you're going to get very different information from if you're maybe looking at the general community. So this was a systematic review that was published that was reporting the prevalence of long COVID in children. And so the graph is showing you the percent of sort of symptoms that were prevalent in different research studies. And the numbers range all the way from sort of 1.5% all the way through up to 70% prevalence. So if you focus, though, on the ones that are more community-based, that have a comparison group, that are more prospective, that are sort of the better conducted studies, people estimate that there is at least one persistent symptom occurring a month or more after having SARS-CoV-2 in kids about 10% of the time, sort of based on some of these US studies. And so again, just kind of to highlight, this is not a rare disease. This is something that we are seeing with significant frequency in kids as well as adults. And what about the trajectory of long COVID in kids? So again, I think this is an area of active research that less is known about the trajectory in children. And then there haven't really been enough studies yet to examine these outcomes that are 12 months and beyond after infection. We know that just like with adults, we see that there are recurrent symptoms that you can get every time you get a SARS-CoV-2 infection. It can flare your symptomatology. And we also know that there's been less reporting of long COVID over time. So more reports sort of in the earlier phases. We do know it's still existing. There's been sort of less testing in a hospital-based setting or a healthcare-based setting, and that just makes it difficult to trend exactly how much there is and what the burden is. But we know we've seen everything from people recovering within a couple of months to having ongoing debilitating illness years down the road. So early on during our research group kind of coming together and sort of discussing our approaches, we really wanted to try to understand some of these clinical features and the burden of long COVID in children and in adolescents. So this was a paper that we published in JAMA Pediatrics back in 2022 that was making the most of the real world data that we had available to us. So we were able to quickly set up research studies that took into account lots of different populations within the United States across multiple different sort of health centers. We looked at outpatient information, inpatient information. We looked at different laboratory tests, diagnoses, vital sign data to try and answer some of these questions. So for this particular study, we were looking at children who had a SARS-CoV-2 test. Then we broke them up into those who tested positive and those who tested negative. And this was done during a time when there was mostly in-hospital or health system-based testing. So there was not really at-home testing being done at this time. Then we looked to see who was developing symptoms in the 1 month to 6 months after having a SARS-CoV-2 infection. And we wanted to kind of get a sense of the relative frequency of what was being more commonly seen in the positive individuals compared to those who were testing negative. And so let me just kind of go forward here. So we had close to 660,000 individuals who were tested between March of 2020 and October of 2021. And there was a close to 10% positivity rate. So we had about close to 60,000 kids who were testing positive. And so what we found, we looked at different symptoms and different conditions, and we were finding things like loss of smell and taste. We were finding things like hair loss, like chest pain, abnormal liver enzymes, generalized pain states, anxiety symptoms, skin rashes, and a lot of fatigue and malaise in these kids. And then we looked at conditions. So these were more sort of like clinical diagnoses that were being made after someone was seeking healthcare. And we found things like myocarditis or heart inflammation, acute respiratory distress, myositis or muscle inflammation, the need for having visits due to mental health treatment, as well as things like thrombophlebitis and thromboembolism. And so what about the differences in how kids and adolescents are presenting compared to how older people are presenting? And so I'm really excited to share with you this study. So this was a paper that was published in JAMA just a couple of months ago. And this is really the landmark study of the Recover Pediatrics prospective cohort. So here they had enrolled over 5,000 kids as well as adolescents with and without evidence of SARS-CoV-2 infection and long COVID, and again looked to see what were some of the more predominant features, and they broke it down into different age groups. So they looked at the 6 to 12-year-olds, and then they looked at an adolescent group as well. And then the box on the right is another study that was published in JAMA that was done in adults that similarly looked at some of the more classic common features and presentations in adults. So if we start sort of on the left-hand side with those younger kids, some of the more predominant symptoms they were experiencing were things like headaches, with trouble with memory, with focusing, with trouble sleeping, as well as abdominal pain. And then if we go fast forward sort of to the right side where we look at the adults, some of those more common symptoms were things like post-exertional malaise, fatigue, brain fog, dizziness, GI symptoms, and palpitations. And then if you go into the middle box and you see some of these adolescents and youth, they had sort of symptoms that were sort of overlapping between what was being seen in kids as well as what was being seen in adults. So daytime sleepiness, muscle ache, body aches, as well as headaches and trouble with memory and with focusing. And so it's going to be a really exciting time over the next 6 to 12 months as more studies from the prospective Recover group is going to be coming, and I can talk a little bit more about that. So it was really important to us to not only focus on what some of those symptoms and conditions were, we also wanted to try and get a sense of what was going on to that individual and sort of their everyday functioning. So we heard already through our stories this morning just what an impact it can have on sort of the everyday experience. And so we wanted to focus on some of these functional outcomes. And so when we think about these, we think about things like one's mental health, about how kids are doing with their sensory focusing and functioning, on their communication abilities, on their motor functioning, on their ability to feed and learn, how well they were able to participate in everyday routines. What about their relationships with their families and their friends, and sleep habits as well as mood status. So again, this is going to be a focus on Recover Pediatrics, and we tried to look at this using some of our health system data as well. So we conducted a retrospective cohort study of 21 children's hospitals in the United States. And we identified kids that had long COVID, who were test positive, who had long COVID, as well as those who were test positive, but that did not have evidence of long COVID. And so we did really extensive reviews of their charts to try and understand what their visits were like, what difficulties they were having, and try to sort of characterize this in some way. And so this is just a graph that summarizes some of those functional impairments into different domains. And so the blue bars represent those that had long COVID, and then the yellow bars are representing those that did not have long COVID. And by far and away, you see those really tall bars on the blue side. So kids that were having long COVID were more likely to miss school, to have missed extracurricular activities, to have school difficulties, and to have new referrals to speech therapy, to physical therapy, to occupational therapy, etc. And they were also more likely to have behavioural or sort of mental health impairments requiring support. And when we did some additional adjustments for some confounders, we found, again, that by far and away, some of the strongest trends that we were seeing was that need for behavioural mental health symptoms, as well as the need for school support, as well as the issue of having that school decline. Okay, so now I'm going to talk a little bit about the prediction, some of the data regarding prediction of long COVID. So this is an area that is very common to people who do epidemiologic studies, trying to identify like who might be at more risk. And so we did this work looking at severe COVID-19 infection in children. So this was trying to figure out who was more at risk of ending up with more severe COVID that might land you in the ICU, where you might need to be on a respirator or maybe needing presses. And so we found that younger children, as well as those who were presenting earlier on in the pandemic, as well as those who had Hispanic ethnicity, were sort of at that higher risk group. And then there were certain medical conditions that put you at an increased risk group as well. And so those were asthma, diabetes, being immune compromised, as well as having a cancer diagnosis. And so we and others have tried to explore these questions about risk factors for long COVID in kids as well. And so some of the findings really show us that it's more the older adolescents. If you're more likely to have it if you're female, and there are certain medical comorbidities that will put you at more risk as well. We definitely see sort of a different flavour of long COVID in those who have had severe COVID-19 infection. We know that those with increased weight status, those with repeat infections, and those with certain influences, social influences of health can be at greater risk as well. There have been some studies also showing that the number of organ systems that you had involved when you got your acute COVID can be sort of predictive of having long COVID as well. And so this is really just sort of, a big picture kind of exploration. It's very clear that that there are people that don't fall into these categories that have, severe debilitating long COVID as well. So we did similar work looking at MISC, the multi-system inflammatory syndrome in children. And so we did some latent class analyses. It's just sort of advanced machine learning techniques to try and see if we could kind of categorize MISC. And we found sort of a mild group of individuals. We found a sort of a more moderate group and a more severe group. And those more severe children tended to be older. They tended to have a lot of inflammation when they were first seen. They tended to have many organ systems involved. They were more likely to have abnormal white counts and low platelet counts, and they were also more likely to have high cardiac marker inflammation, as well as more impaired renal function. Okay, so now I want to talk a little bit about prevention. So we had the fortune of having Dr. Peter Hotez speak to us yesterday. So he's an absolute legend in the infectious diseases pediatric community for all the work that he has done around developing vaccines for neglected diseases. And so it was really wonderful to hear him speak yesterday. So he ended up referencing one of our studies that was published in Pediatrics that was trying to answer the question, can vaccines prevent long COVID in children? So just wanted to give you a little bit of background about that study. study. So this was a study that we did in over 1 million vaccinated and unvaccinated children from 17 different health systems across the country, looking at real-world data. And this is a pretty common approach that's done using conditional logistic regression models to try to evaluate vaccine effectiveness. So it's done a lot for annual flu vaccines, for COVID vaccines, et cetera. And so we tried to make sure that we were adjusting for different important confounders when we did our analyses. And so the main takeaway is that vaccines were effective at preventing long COVID. So when you look at all the data, it was sort of moderately effective at 42%. But I want to highlight that we talked about adolescents being at more risk of having long COVID than kids. So we found if we just looked at the adolescent population, it was closer to 50%. And we also found that there was a waning immunity effect. There was a question that had come up yesterday about why are we seeing differences? Why do some studies show us that the vaccine works and maybe other studies showing us that it doesn't work? You have to take into account sort of the time from vaccination too. So the biggest bang for your buck in protection is really going to be within those first 6 months. So it is most effective at preventing long COVID if it's within sort of 6 months of receiving the vaccine. And so this was sort of an important message that we provided to our pediatric community. It was coming at a time when people were wondering, should I get my adolescent vaccinated, or is it really worthwhile to do vaccines in children? And so I think this is really sort of an important message that yes, it can make a difference in this way, as well as minimizing severe COVID. I think another question had come up in terms of why do vaccines work and what is sort of the mechanism here. So I think there's still a lot that needs to be learnt about this. We tried to do something called mediation analyses. So we were trying to see, was it because we were preventing severe COVID and because we were preventing COVID, and is that why it was reducing that risk of long COVID? And it does look like there was some signal there that that may well be the case. But again, more studies need to be done in sort of this area to answer these questions. Okay, so now I'm going to turn to talking about treatment. And, I think we're at a point where we're all just hungry for treatment and what can we do and how can we alleviate the suffering of people that are having long COVID. And so right now, as far as the Recover Initiative is concerned, we don't have any pediatric clinical trials underway at the moment. There are a number of trials that are being done in adults, and so I just summarized a few of those trials here for you. So there are a number of different groups that are exploring different aspects of long COVID and are doing phase 2 randomized controlled trials across multiple different centers around the country. So one is focusing on POTS therapies, or postural orthostatic tachycardia syndrome. There are some really innovative strategies coming from the cognitive dysfunction group. So they're using Brain HQ. It is an online brain sort of rehabilitation platform, as well as transcranial electric stimulation. So that has been shown to help with sort of cognitive function improvement. There is a lot of cardiac rehabilitation work that's being done to help with exercise intolerance and fatigue. There are certain drugs that are being looked at to promote wakefulness and overcome sleep disturbance. And there is also this body of research that suggests that there may be some viral persistence. And so there's a study that's looking at longer courses of nirmatrelvir, ritonavir, or Paxlovid to try to explore that question about persistence as well. And so while we're sort of waiting urgently for the pediatric trials to come about in Recover, one thing that we can do is to try and think about how we can better optimize the care for these kids with long COVID. And so I think you in Canada have an outstanding sort of community group. You get to sort of help to advocate for the care of your children and individuals with long COVID. And similarly, we have a number of sort of grassroots community organizations in the US. And they're a wonderful resource. And whenever I give talks to providers, I really let them know to look at these websites because you can learn a lot about how to help to manage these patients. And so this was one example of that. So it was a paper that sort of talked about the patient perspective on how we can sort of optimize the care in the clinic setting. And I really like this. It's super practical. It's just things like providing general information before someone comes to clinic so they know know what to expect and what's going to be coming. Thinking about that intake process, making sure that there's a virtual option as well as an inpatient or in-person option, since that intake process can be very, exhausting, going through all of those long symptoms and conditions and getting the medication history, etc. I think it's also really critical to try and identify a lead person, a lead provider who can really play that role of sort of team captain. They have all that information from that intake. They can help to really serve as a liaison with all these other medical providers and other members of the multidisciplinary team. And then really thinking about who those referring providers are, making sure that they're interconnected and communicating, and making sure that there's appropriate and frequent follow-up with those team members as well. And then I think it's also important for us to be thinking about how to tap them into some of those other resources sort of outside of that healthcare setting. So are there additional school-based supports that we can get them into and let them know about? Are there any other sort of social and psychological supports that they may need? Are there long COVID support groups that we can tap them into? Or are there any research studies that we know of that we can kind of help to link them to as well? And so, when we think about long COVID in the pediatric world, the evaluation that we do is sort of similar to what we might be doing with an adult setting as well. So we really try to determine the symptoms and the impact that it's having on their everyday function. We try to assess what other evaluations are going to need to be helpful. And we also try to identify red flags. So what are the things that just are not sounding right, that are really worrisome, that may just warrant urgent further testing and other evaluations? And is there a way for us to sort of differentiate long COVID from maybe other conditions that might require a different therapeutic approach? So after we do that, we do our sort of full examination and our workup of kids. And this is coming from a consensus guideline document that the Physical Medicine and Rehabilitation Group has published on, if anyone's interested in sort of learning more. They have a really nice summary of sort of the approach to the care of children with long COVID, including the management of some of the more common manifestations that I had just described. So this is some of the frameworks of how we would manage these kids when we see them in clinic. So, again, really taking the time to do a very thorough physical exam, including doing sort of provocative musculoskeletal tests to elicit where there might be areas of pain, to think about POTS and doing orthostatic vitals, to do some sort of endurance testing, and this could be a 6-minute walk test, to again do a 30-second sit to stand to evaluate for any sort of tachycardia, to do some basic screening blood work. So most of these end up being normal, but it's a good way of ruling out other things that might require more dedicated treatments. And then really just thinking about that tailored approach to that individual. So if someone's having cardiopulmonary symptoms with fatigue, exercise intolerance, then really going down that next step, which is potentially imaging, which is pulmonary function testing, which might be EKGs or sort of other referrals to some of those groups to help with the management of those specific issues. And then that team captain really needs to think about who needs to be involved in that multidisciplinary care. And this is just sort of an example of some of the different team members that we get involved to help us just on the medical side. And then, of course, we can't forget the whole biopsychosocial framework. So we talked about the medical needs, but again, we do have to be thinking about some of those ways to help those kids and those youth with everyday functioning as well. And so these might incorporate things like rehabilitation, physical therapy, occupational therapy, speech language therapy, and educational specialists. And there's so many experts in this area in the room today, and I'm thrilled to see that. And then we have to think about those socio-emotional needs like psychology, whether they need psychiatry referrals to help more with sort of the coping mechanisms, as well as school counselor input and help with peer support groups. I think that's really important, especially to our adolescent populations. So I think that I could spend, several hours talking about what we next need to be doing in pediatric research when it comes to long COVID. But within Recover, there are a few key domains that I wanted to talk about in terms of some of our next steps. So the pediatric prospective group is really going to be focusing on some of the underlying mechanisms of what's going on to contribute to long COVID in children. How is that different to what has been studied in adults? The other piece to this is really going to be in treatment. So based on what we find with those mechanistic studies, are there specific sort of areas that we should be targeting when we're talking about trials in kids? And then we can also use a lot of our real world data to try to understand some of the additional experiences of people, some of the different symptomatology and trajectories, as well as some of that lived experience that I mentioned before. So I mentioned what Recover Pediatrics is looking to do. I think you're all familiar with some of the mechanisms that have so far been proposed. Many of these studies are still very much focused in adults. We do see some evidence of this occurring in kids too, but we really need some more sort of dedicated pediatric studies to look at how there might be some differences in pediatrics compared with adults. And then some of the work that we've been focusing on is, again, we use a lot of real world data to try to answer questions, and we're going to try and take that one step further to try and extract information from clinical notes, which have really rich information in terms of the full symptom spectrum of what people are experiencing and how it's impacting their everyday lives. So we are doing a lot of work around what we call NLP to really try to understand and characterize this better in kids. This is just some sort of next steps for the Recover Pediatric group. So the JAMA paper that I told you about was looking at experiences in the 6 years and older age group. So there is going to be some work looking at long COVID in younger kids, so under 5 years of age. There's going to be some work looking at the mechanisms of disease, as I described, looking at the potential risk and resiliency factors, as well as characterizing different patterns in kids and seeing again how it might be different to adults. And so this is going to be some work that's going to be published over the next 6 to 12 months. So some really exciting things are coming. And then some of the work that we're doing as well is, while we're waiting on those pediatric clinical trials, there are some ways that we might be able to apply advanced statistical techniques to try to mimic randomized controlled trials using observational data. So this gives us some benefits. We can do this quickly. We can really provide some insights that might help with the design of randomized controlled trials. And we've already sort of shown that we can do this quite well to explore other things. So we've done this approach looking at vaccine effectiveness against COVID. We've done this for looking at Paxlovid effectiveness. We're looking at this now in steroids as a treatment for long COVID symptoms, as well as other more directive therapies for long COVID in pediatrics. So I'm going to end there just to make sure that there's enough time for questions. But, I think the big take-home points here is that we really need to be spreading the word to our communities that long COVID exists in kids just as much as it does in adults, that there are a lot of overlapping characteristics and features, but there are certainly some sort of subtle differences that we need to be understanding and exploring more. We have to think about not just the sort of medical side of things, we have to think about the impact on their everyday functioning, their school performance, their relationships, as well as what those socio-emotional needs are. And we urgently need to be focusing on understanding those mechanisms of what is going on pathophysiologically. We need to be working on effective treatments, evidence-based effective treatments, and also thinking about that whole complete picture of their sort of everyday functioning and ability to thrive in the community. So I just wanted to end with a quotation. So this comes from one of my colleagues at Rainbow Babies Children's Hospital. She's an infectious diseases physician who's running one of the long COVID clinics over there. And I think that this is just a really powerful message that I share with providers and community members. So the number one thing that we can do to help these kids is to listen to them and to believe them and to validate their illness. There is a lot of disbelief out there that this condition even exists, and trust me, it does. And so these kids are constantly hearing that it is just their anxiety or it is just in their head or whatever, and that is neither helpful nor true. Getting a proper diagnosis of long COVID and getting that validation that it isn't all in my head can go a long way towards helping these children adjust to having a chronic illness. So thank you so much for your attention and your time. I wanted to thank the Recover Initiative, the group that we get to work with in PedsNet and PCORNet, all of our participating individuals and staff. We have a number of community representatives that we do research with, and a number of sort of health systems that we work with all of the research studies that we do. So again, thank you so much, and hopefully there's some time for questions. Appreciate it.
Thanks so much, Dr. Rao, and I think that was an amazing talk, and it was a great overview, and Ethan's video really, set the tone for us today to really give us a sense of the human impact, and it just, brings so much focus to the urgent work and the great work that you're doing, so thank you so much.
Thank you.
All right, so I'll moderate the talk, and I see that there's already a lot of interest within the room, so we'll start off with the in-person question and then go to the online.
Hi, my name is Dr. Joe Vipon. I'm the co-chair of the Canadian COVID Society. I just find it so painful to hear about pediatric long COVID and to hear Ethan's story, and I can't remember the girl's name that you mentioned as well. I would suspect that probably both of those kids got their COVID initially in a school. And I'm just wondering if you can comment on the fact that at least in Canada, generally our public health systems have not acknowledged that. I mean, certainly early on, they flatly denied that schools were a source of transmission. There's also been recurrent statements reassuring parents that schools are safe despite no changes made to prevent mitigation. And as you know, the best way to avoid long COVID is to prevent COVID from the beginning. So just a comment on how our systems are failing our kids.
Yeah, it's such an important, challenging question. I'm not sure I'm going to be able to do it the full justice that it deserves. But we do know that not only will it sort of prevent that initial episode, but we have to think about how we might be able to prevent those sort of subsequent flares that might be happening if someone has, long COVID in the first place. We know that schools is a way that viruses and other pathogens spread. It's just what happens. You get, kids in a close environment and they transmit diseases and infections from one group to another. And that's just a nature of being in sort of a closed environment. I think that there has been sort of a lot of debate in terms of what we do in schools and needing to balance the whole, how do we make sure that we have kids continue to receive the education that they deserve while also keeping them safe. And so you've seen lots of different jurisdictions have a lot of different sort of takes on that. I think that as a infectious diseases specialist, I do infection prevention as well. So my brain is always focused on, what are some of the preventative strategies that we can do? Masking, distancing, good ventilation, improving circulation. So, that's the stuff that we often talk about and work through. But I recognize that every sort of government group and every school district sort of has different ways of addressing it and focusing it. So I don't have sort of a big high level sort of editorial comment here, only to say that we do have sort of steps that we can take to minimize sort of the risk of transmission, and hopefully government can sort of listen to the voices of pediatric people, public health people, to try to make those changes take place.
So, hi, I'm also involved in the Canadian COVID Society. I'm on the board with Joe, and Nancy here also is our executive director. We hope we get to present some more about our society a little bit later on. But I myself am a physician, internal medicine, and HIV practitioner, Dr. Marie-Michelle Bellon, and I have a son, 17 years old, who lives with long COVID. So I can relate to a lot of things that were said, and especially about the medical gaslighting. But yes, I wanted to re-emphasize about prevention. 1 in 10 is huge. I'm sure that there are lots of parents in this room. Are you scared when you're sending your children to school? Do you feel like you're playing Russian roulette? Because this is how I feel. I also have a daughter. And actually, my son has had COVID 7 times, and my daughter at least 4. And recover, yes, but recover and then get reinfected. So we have to think about schools, we have to think about ways to decrease transmission in schools, because this is it's a tremendous problem, and we cannot only look at this situation from an individual side of it, because this is a society problem. So yeah, this is what I have to say.
Yeah.
Nancy wants to add something.
Thank you for your comment.
It's regarding ventilation. There are really good examples, and the University of Colorado has done wonders with Shelley Miller and Jose Luis Jimenez. For 2 years, they had no on-campus, infection. And so it's possible, it's not fatalistic to get infected in school. And if we put the right measures, it gives so much thing. The ASHRAE 241, they said that if you invest $800 for a classroom, the repercussion in the society is $7,000. So this is in prevention and secondary infections to the family. So this is all I want to say.
And thank you for your comment as well.
Sorry, we just need to alternate with the online as well, so thank you. So a very quick question and then another question. So first is, what was the autoimmune skin condition that you mentioned called?
Yeah, it wasn't given a specific name. It was just the rheumatologist had done these sort of extensive reviews and sort of ruled out some of the common ones. But that was what they ultimately said, most likely rare autoimmune condition, but didn't have a specific name.
Okay, thank you. And then the other question is just about how can we do better about the data in terms of how long COVID is reported? Is there anything that long COVID clinics can do, or governments can do in terms of the data?
Yeah, so great question. So it sounds like it's more about how can we use the data to get a sense of just how prevalent it is in the community and whatnot. Yeah, so we saw that graph that showed that huge variability. So I think some of it comes down to the definitions that are being used, and why I think we need to have sort of a more standard definition for long COVID for research. That's going to help clinical care. It's going to help families and people with lived experience as well. And I think that there's sort of good ways to do research. So I think making sure that you have you're measuring things sort of in a standardized, systematic way, making sure that you have sort of comparison or control groups. And if you're trying to get sort of more of a swath of what's going on in the community, just making sure that you're doing something that's more representative of the whole community, rather than anything that might bias your data. So an example of that is, if you do a study looking at only hospitalized patients, you're going to get a very different answer from if you do it from, say, a school-based survey, for example.
Thank you so much. We have another question from the room.
Good morning. Thank you for that great talk. Much appreciated, and thank you for traveling here.
Thank you.
First is a comment. University of Cambridge study. They looked at a hospital where there were a lot of nosocomial hospital-acquired infections among all staff on the COVID wards and throughout the hospital, but it was very severe in the COVID ward, from food services to techs to phlebotomists, nurses, doctors. And they decided to try one thing at a time and then decide which measures they'd implement. They made a rule that everyone who went into that ward had to wear the equivalent of an N100 mask. And at the end of 3 months, there had been no COVID infections, while the rest of the hospital, the control, who wore floppy blue surgical masks, there was no change, and there were ongoing COVID infections. So that shows one, to me, powerful change that can be made quickly without even changing ventilation systems, which is much needed. My question is from a talk yesterday where we heard that a COVID infection drops gray matter by 10%. I asked about repeated infections and I asked about kids, and the thought was plasticity will compensate for that loss, neuroplasticity. But is it possible it can be like concussion, where we thought, oh well, kids bounce back, but we know it's a lifelong cumulative problem What's your view on that? Do you have one? Is there evidence to support things either way?
Yeah, excellent question and point. So, I think that I think what your question really lets us think about is how complex this is an issue in pediatrics, because we know that there are things like the brain is still developing, that there is neuroplasticity, that there is sort of this opportunity for compensation and recovery in kids because things are still kind of growing and developing. We also know that there needs to be time spent to answer that question. So I think this really speaks to the need to have more research looking at the long-term impacts. So kids are developing and growing, and so how they're impacted at age 12 might be different from how they're impacted at age 17 or 18. And so there are a number of studies, of longitudinal studies, that are looking at this question of sort of neurodevelopment over time. So Recover is one of them. There are many groups around the world doing that. So my hope is that we'll have more understanding of what is taking place after you get that initial hit. What is sort of the longer term sort of consequence. We've already started to see some studies showing that it's affecting some aspects of development. So milestones may not be met, delayed milestones in sort of younger kids that are having COVID, that sort of thing. So great question. Don't have great answers for you right now, but hopefully we'll be able to answer that with more long follow-up.
And do we have an online question?
Yes. Got a few, but I'll, and apologies that they won't go all answered, but perhaps if there's time, there might be opportunities for others to actually try and answer some of these questions. This is about genetic susceptibility. Is there any chance that if both parents have long COVID, the child is more likely to get long COVID if they have COVID?
Yeah, I love that question. So I know that Recover Pediatrics is going to be looking at a lot of the sort of metabolomics and sort of genetic sequences that have been sort of collected over the past year. And some of that will explore that question about if you have parents that have long COVID, does that put you at risk? We definitely know that that we've heard stories where that has been the case, where if we see it in one family member, that other kids might see it as well, but it's not 100%, right? So there's clearly some potential genetic predisposition, but hopefully Recover Peds and some of these other groups can sort of answer that question.
Perfect. And so we'll have time for just one last question. Take it away.
Hi. So this is a question about a family that's in one of our support groups. We're Long COVID Kids Canada. There's a family with a son who has been diagnosed with POTS, MCAS, aggressive systemic mastocytosis, and autoimmune hepatitis. He's very ill. He can only stand for 4-minute increments without fainting. He's pretty much bedbound, and because of the COVID clinics closing in our area, he's pretty much been left without care. He did have appropriate care for the first year and a half, but because his case is so bad, if the family feels like they've been abandoned. I'm just wondering if you've come across any other cases as such, and what kind of advice can we give to this type of situation?
Yeah, so I would say that that family is not alone, that we have definitely seen those sorts of presentations, especially in adolescence. And I've spent time with rheumatologists who have taught me about sort of mast cell activation syndrome and how it can be overlapping with a lot of features of long COVID as well. I think this gets really challenging, when you start having this sort of long COVID clinic in this group that you can get care, and then that clinic goes away and you're sort of left sort of struggling with how that is all going to go. I think that really comes back down to then who's going to be your team captain. So who's going to be that person to help to navigate the care? Do you have a primary care provider that you can turn to, or are there any other sort of specialists where you've got a good relationship with one provider who can then sort of help to continue that care? So again, I'm not sure I have great sort of answers or solutions, but it is something where having a person who's a provider who can really play that sort of primary role of helping to tap into those resources is really going to be key. One thing I might add is Recover has a lot of interesting sort of useful information on its website. It talks about the studies, but the CDC as well. It has things like how to talk to your providers about long COVID. And so sometimes this community has to educate, the family practice docs and the pediatricians and those other providers in terms of, here's how long COVID is presenting in kids, and here is sort of what I need. And so I think we have to sort of be empowering this community to be able to know exactly how to educate those providers to really give them the care that they need.
Thank you so much.
Thank you.
Thank you so much again, Dr. Rao. That was an amazing, amazing talk and wonderful discussions. I have to say, listening to the questions, particularly the one about autoimmune, general phenomena, that's definitely something that we see in the adult population. It reminds me of a paper that Dr. Mukherjee published a year and a half ago in the ERJ, and where she had worked with her rheumatology colleagues, and they found that the ANA, so one of the markers for lupus, was elevated, and they felt that there was a connection to some sort of rheumatologic diagnosis, although not, to the level that really meets sort of any rheumatologic vasculitic diagnosis, but clearly there's something there. So it's very interesting to see that there are themes in adults that are also echoed in pediatrics. And perhaps in the future, another avenue is to really pool our combined observations in the adults and the pediatrics to give greater power to find out some of these phenotypes. And truly, I suspect that what we'll end up finding is that long COVID is one thing, and there are subpopulations, and that can predict who can respond best to which type of treatment. So very fascinating talk and given us all a lot to think about.